So welcome everybody to our tumor board and case discussions of the Skull-based committee of the World Federation. It's an honor to be here again with our panel, and we're gonna go directly to cases to save time. We have the first to presenter here, Dr. Ditzel from Brazil, and he has a very challenged case that will require the opinion of the panel. Welcome, Linda. I see your picture just popped there. And we'll start with Leo presenting this case. I'm gonna share here the pictures we have. Is this a good one to start, Dr.?
Yes, that's perfect.
So go ahead and tell us what's going on.
Okay, so this young lady is a 17-year-old young lady from southern Brazil. She has neurofibromatosis. That's her mother actually holding her hair because she's unable to raise her right arm above the level of her shoulder right now. So obviously she's known about this disease and about this specific tumor now for a while. She's been subjected to 2 prior surgeries by plastics. By the plastics team, they were able to reduce a little bit. This is a plexiform neurofibroma, giant plexiform neurofibroma, but the issue is right now it's 17. You can appreciate through the CT scout the size of the mass. So it's not only causing pain, also deformity, and slowly pushing her head towards the left. She doesn't, surprisingly, she doesn't have a lot of neurologic deficit at this point, except for the difficulty with raising her upper right extremity above the level of the shoulder. Her sensitivity is, her sensory is preserved, muscle strength is preserved, but she does have pain. She does have a lot of pain, constant pain. It's affecting her day-to-day life and quality of life, and this is the sort of deformity we're dealing with. So the issue here is, so she came to us because she has this giant mass on the lateral surface of her neck, and the mass you will see from the images not only causes this gigantic and impressive deformity of the craniovertebral junction and upper cervical spine, but there you go. So this is the image that I think would be probably the most valuable for the panel. So the guys at Head and Neck team say they can reduce the lesion. The lesion is supplied by branches of the external carotid artery on both sides, branches of the vertebral arteries on both sides. Her left vertebral artery is dominant. And also occipital arteries. So endovascular team thinks that they might be able to reduce vascularity here, do a pre-op embolization. The head and neck team thinks they can reduce quite a bit of the plexiform neurofibroma. Mind you, she's been subjected already to 2 surgeries in the past, which were cytoreduction surgeries, obviously not curative, but she tells us that it didn't really do much for her at the time, and this thing is growing and causing this deformity, which is quite impressive when you look at the spinal cord and the amount of bone compression that we're dealing with here. So the issue is, I guess the question for the panel is, should we from neurosurgery do anything with this? Because I mean, she, other than the difficulty I related, portrayed to you guys regarding her upper right limb, there isn't a lot of neurologic deficit at this point. And also the tumor, I think that I mentioned the previous image, you can see that the tumor goes all the way to the prevertebral space. She doesn't really have much clivus left. There you go. So the tumor goes all the way to the prevertebral space. She's having difficulty swallowing at this point. And should we just attack this and leave it to the head and neck guys to deal with the cervical mass? Should we get involved? And if so, how far should we go? Because we've already consulted also the spine guys, and they're really wary of going into this, because where would we be able to fix this, you know, in terms of reconstruction? Her occipital bone still preserved, but the posterior cervical elements of the upper spine are gone, which you can appreciate from this 3D rendering. So that's
So,
basically it.
is this a 3D reconstruction of her
Yes,
spine and
yes. This
or-
is a CT 3D reconstruction of her upper cervical spine. So you can see that she has C1 through C4 hypoplasia with varying degrees of fusion. Her posterior elements are gone. It's almost as if C1 and C2 were rotated outward posteriorly.
Yeah. And so just so I understand, this is a 3D printed or this is a 3D
No, this is
creation?
this is the CT reconstruction. It's not a print, which is pretty good, right?
Yeah, it's very nice. So this was created in the 3D, like a virtual, this is a
Exactly.
computer
Yes.
generated.
Correct.
Very, very nice. Yeah. So, I mean, this is very challenging, no question here. So let's see,
I think you can keep scrolling through the images.
while people talk.
There should be videos there as well.
Yeah, the videos is what I have to stop sharing and find the video here again to find the videos. Let's see if I can get a video. Can you see this video now?
Yes. So that's a coronal view on T2. You can see the mass on the lateral surface of the neck. She has no intracranial disease, no cerebral disease.
Yeah. So I think I have to just stop sharing and share again the other videos. I think you have a couple, right?
Yes, there should be 4 or 5, but they're all very short.
Is this the same?
Yes, I think this is the same you started.
Let me do it again.
There you go.
Is this a different one?
Yes. So this one is just to show us how large the mass is. It goes all the way around her neck, all the way to bilateral occipital regions. Her entire right parietal temporal region is also affected. So this thing basically wraps around her whole head. Obviously, the idea is not to. So this is the sagittal bone window, the CT from which we did that 3D rendering.
It's quite deformed.
Mm-hmm.
So just want to stop here. Look, I think
I think that's the odontoid.
The odontoid is almost like broken, right? It goes forward again, goes
and
up
tilted forward.
and then it's tilted forward. Wow. Wow, I understand why people don't want to touch this, my friend.
Mm-hmm. You notice that she has no clivus, and if we were to do anything from the anterior perspective, would have to be transoral because it's so low.
And let's just stop here. Like, look at the verts are laterally on the skin things right there. Are they involved like a part of the tumor too? Huh?
And she has a dominant left vertebral artery, so at least we have that.
Yeah.
But interestingly, it's caused all this deformity, but it's not within the canal. So other than the deformity itself, there isn't direct tumor compression. It's more of the effect of the long-term bone destruction.
Yeah, so my understanding, so if you look, do you see my arrow or no?
Yes.
Yeah, I think it's almost like the spine comes this way and then it's broken, goes that way again, right? So the odontoid relationship here with the C1 arch, it's preserved, but then is about C2, C3, where there's like a swan neck with the spinal cord. It's almost like more than the skull base, is almost like the main problem is like upper cervical, right? The main problem.
Yes.
But the tumor goes all the way there. All right, so
I think you have a couple more videos. You should be able to see. Yes, I think so.
Maybe have one more.
Probably.
I have this one. Is that Oh no, that's just a picture.
That's a picture. Well, but then you've seen coronal, sagittal, and bone reconstruction,
Yeah,
so I think we
those are
should be
the
able to
ones that
go
I
from
got
there.
open here, Leo. I can try to open them again, but
Yeah, but it's fine. I think
yeah,
the main gist of things is already
yeah.
displayed. So
So Soichi, do you guys see this type of problem in Japan?
No, I've never seen cases like this before.
Mm-hmm. But
It's very challenging.
do you see a lot of neurofibromatosis type 1 there with, you know?
Right.
Yeah,
Yeah, but this is just so rare. Yeah.
yeah, yeah. How about you, David? South Africa there, do you see anything like that?
I see a fair amount of type 2, see almost no type 1 disease.
Yeah.
Yeah, this looks like a case you're going to see once or twice in a career.
Yeah.
And understandably,
Yeah, let me
a
tell
head
you,
scratching case.
I'll tell you a quick story before we talk about this. I had a very similar patient with syndromic. I don't remember if it was necessarily um, NF1, but the patient didn't have one lung, he had a lot of deformity on the neck, and the odontoid was also pushing on the spinal cord. And when we decided to go for surgery, and we were planning to go and perform at least a decompression of the odontoid endonasal. And when we put the patient asleep, like anesthesia couldn't maintain the patient because he had only one lung, and the deformity of the thorax didn't allow proper ventilation. The anesthesia aborted, and the chief of anesthesia basically said, we're not going to anesthetize this patient evermore, because they were very stressed. They almost lost the patient just in induction. So we never able to operate. Like they woke the patient up because they couldn't maintain proper anesthesia. And that was the only time in my career. I went and talked to the family, the patient afterwards. I'm sorry, but we're not going to proceed. The patient was from a different state, came all the way to us, and we couldn't do it, Leo. I don't know I think that was after your time with us here.
yes,
It was a sensation of what can we do, right? So sometimes we have to be like, sometimes do nothing is better for the patient. So I don't know. This is a very challenging case. Doo-Sik, what do you think about this case? What tell us, what would you do? Like, what would be your thoughts about this?
Yeah, I have very similar case to this patient, and my patient complained of the very huge encephalocele, and around the C1 to C2, 3 areas. I just performed the system content, and then perform the muscular flap from the latissimus dorsi, so assisted by the plastic surgeons. But it took maybe 18 hours operation time. And next morning, so we finished the operations, but still, and after operations, the patient cannot standing and sitting there. Is now the bedridden status. Now in my patient is on admissions for several months. So thereafter, I'm sorry, but the neurofibromatosis type 1 is not curable, and I don't think that we can do the operations for this patient. I'm sorry.
Yeah, it's a good experience, important insight, because you had one that didn't go very well. That's the way we think, right? In neurosurgery, every surgeon thinks that way, right? Linda, had one problem, then you don't want to have that problem again. So I'm glad you brought it here, Leo. Like, Linda, what do you think?
Yeah, I fully agree. I think certainly this is such a challenging case beyond anything I've seen before. We do see a number of folks who have incredible angles of that C1, C2 clivus region, and I'm always amazed that they look so good. They usually present with something mild, whether it be a little bit of hoarseness or facial weakness or whatnot. And I fully agree with you that leaving them to their natural state. I think the biggest question that all of you are saying is, what is the indication for surgery to incur any of this risk, whether it's intubation or whatnot? And Leo, it sounds like, I mean, God bless you for attacking this even, but it sounds like it's right now cosmetic. Is that right? Because the hoarseness you think is
Yes.
largely infiltrative in the
So
prevertebral space.
yeah, so if you look at the pictures of the actual patients, she's basically having her head tilted by this tumor left. So she has no quality of life because she doesn't want to go outside, she doesn't want to go to school, she doesn't want to move on with her life. There's some amount of pain involved with this, and it's slowly progressing, slowly getting worse over the years. So she's consulted a bunch of head and neck surgeons. Some of them said, no, we can do some cytoreduction. Some of them said, no, we shouldn't touch this. I guess she has, at this point, I've referred her to a head and neck surgeon who said he would be able to do something in terms of reducing the amount of tumor she has on the neck. But the point is, should we do anything with the spine or not? Because that image is impressive, right? So on one hand, you feel like, hey, I want to help this because there's so much port compression. Sooner or later, something's going to happen. Even if she falls down, you know, at a home, she's at risk of being quadriplegic. But at the same time, I feel like she's doing so well because she has no significant neurologic deficit other than the see. So just for a second, Dr. Prevedello, the previous image, you can see that the lesion goes all the way through the hair there. The hair is hiding the lesion, but it's way in the back. There's folds of tumor going on there. And I think that the head and neck guys can do something about the cervical mass, but we've been consulted regarding the craniovertebral junction, the upper cervical spine. Should we do anything about it? And I guess my feeling is that maybe we should just leave it alone, you know, and then just try and do something if it ever comes to a point where she's progressing in terms of neurologic deficit, which thankfully hasn't happened yet.
Yeah, I think the plan you have, Leo, is, in my opinion, is very accurate. That's what I would probably do as well in a situation like this. I mean, she's walking, right? I think
She is, yes.
you may touch this and you have somebody on the bed like Doo-Sik mentioned. And how old is she?
17.
17. It's so sad. I probably would go the same plan, you know, let nature take the course for, and then if she start getting deficit, then you need to tackle, and then you have a better justification, because I think the chance of complication here is so high. Don't you think, David?
So, I mean, I think Linda's right. Indication here for me is the most important question is, do you have a good reason to do something? Pain, I think surgery is likely not to reduce pain substantially. The quality of life and the torticollis, I'd be very surprised if that can if there can be much change to that following surgery. And cytoreduction, the advantage that you're going to achieve in this condition, I think, is limited. There are some conditions which we can manage and we can't cure, and this is one of those. And I'm not sure that surgery is a solution here, and particularly while her symptoms are not progressive. I think once you have progressive symptoms, you have a much stronger indication, because I can see us making her a lot worse than she is presently, and you know, that would be a disaster.
So let's assume for a second that she's progressing. What would you guys recommend then? Would we do a transoral odontoidectomy? I mean, not really an odontoidectomy, because there's this bone mass there with ligament and so on, and a bunch of tumor. But let's say she is progressing and we wanted to do something. What would be your idea regarding how to approach this?
Well, I think in that instance, what is the progression? Is it airway compromise? Is it a progressive?
It's starting. So that's a good point. So the airway is not compromised at this point, but she's having swallowing disorders. So every time she comes to see me in clinic, she has a little cup with iced coffee in it, because it's what she can handle at this point. So she's not at the point of malnutrition, losing weight, anything like that, but she's having issues swallowing. We can see that from the palate involvement in the images there. So the back of her throat is just slowly being taken by tumor, and this is something that the head and neck guys won't reach. so it will wind up coming towards us. So
I have to
Yeah,
say, I think that's a difficult one. You know, is this the fact that we've got neural involvement, or is it a functional impairment, a mechanical functional impairment, and try and ascertain where that is?
no, that's mechanic. That's mechanic for sure.
Mechanical?
Yeah, the
Yeah.
mass is just blocking the just slowly blocking her throat. Yeah, but slowly, mind you, it's not something that's
Yeah, I
acute.
think that is there are two different things, Leo. I agree with you. Probably that will require the decompression, take at least most of that tumor out. I think that's something that, like you said, with the head neck direct approach, you can get that resected out of there. The question is again if you need then to do something with the spinal cord there, right? I think though if she developed, like David is saying, the issues are like spasticity and start having issues to kind of walk, become
Right.
tetraparatic, that type of thing, then you're gonna need to go with the, you know, with the spine approach, probably do like a major cervical scoliosis type of surgery, kind of try to kind of recorrect that thing, put
Yeah, so
screws and
the issue is that so we did consult one of the spine guys, and he said we don't have any bone to reconstruct from the posterior approach. And the thing is, what scares me is, let's say you decompress that mass. What happens to that spinal cord? Where is it gonna go? You know, right now it's settled in that position, that C position, that S-shaped position. In terms of space, what would you
Yeah.
do? Would we have
Yeah,
to do some
definitely need
practice
to
sort of
monitor
straighten
our
it?
SSCP's motor and try to correct. Like Doo-Sik is laughing because you know he's
He's been there.
that situation is like not easy, right, Doo-Sik?
Just
But
to make it clear, I'm not advocating that we should operate on this. I brought this case because it's challenging. I told her I would present it, and she was very excited. She was like, "Oh, really? People from all over the world. I want to hear their opinion because it's such an uncommon and difficult case." So I'm not necessarily advocating. I think that just for the sake of discussion, I wanted to know if we were to approach, what would we do? What would you do, Dr. Prevedello? What would be your, let's say she's...
No, I think, yeah, if the deterioration, if there's motor deterioration, then I will, like I said, I mean, I'm not a spine person, but I think a lot of the problem is spine, and try to get the people specialized in scoliosis to, probably you need to do some cracks there, like some osteotomies on the spinal and the vertebral bodies, and kind of re-correct there. But I don't know if it's possible or not. You know, they probably will need a craniocervical junction, kind of just fusion there as well. Try to realign, do everything, probably multiple hours. This would be an issue, I think, with the, you know, like monitoring the spinal cord function, you know, the SSCP's motors, and try to align that. But I think it's high chance of having an outcome like Doo-Sik mentioned, you know, that things don't go well. So that's why I think we'll only touch this if she's kind of going that way anyways. I wouldn't touch at this point. That's my opinion.
Okay.
Any else? Soichi, do you have any different idea? Like, do you think acting before she deteriorates is better?
Well, no, I think all we can do is to minimize her symptoms if she had some serious symptoms like swallowing difficulty or, spasticity, and we cannot, cure her completely. So we should focus on relieving her symptoms. And I would do remove surgery from laterally, because it will provide a large, corridor to the tumor, also in the precrival lesion. But it's not, it's still palliative. So I don't think we can do much, to her.
Yeah, go ahead, David.
Yeah, I was curious to hear, was there any consideration regarding trying to embolize this mass, and what
Yes.
if
So she did an angiogram. So she did an angiogram last week, which showed that the tumor is There's one image that's very interesting. If Dr. Prevedello can show the coronal view, the video. So if you look at the tumor is not only that lateral mass, but also both occipital regions, her entire temporal parietal region. It's almost like a fungus that's growing underneath the skin and going around her skull. So it's impossible to remove everything. What I questioned the endovascular guys is if we were to, they said it's doable because the tumor is supplied by branches of the external carotids, the external carotids, okay, so just a second. There's another coronal one that goes all the way around the head, and then we can appreciate it better. But basically the lesion is supplied by branches of the external carotids, the vertebrals, and mainly the occipital arteries. So they can embolize that, but I'm sure recently I remember I did a lumos jugulare, a jugular foramen tumor that was embolized, and we dealt with skin necrosis. So this is something that I fear in this case. See, look at that, look at the mass.
This part, right?
Yeah, but if you keep going, you'll see that it goes all the way around the head. Almost like a plaque.
Yeah, it does look like a plaque.
So it is embolizable, I would say. It is doable, but I'm not sure how much embolization we should pursue in this case, because I don't know. I've had issues with skin necrosis with very large embolizations and this close to the skin.
Yeah. Yeah, not easy. I think I will ask there's attendees there. If anyone has a different opinion, you guys can send in the chat and we can bring you to talk as well. But I think for the most part, people tend to be conservative, Leo, I think, anywhere around the world for this challenge case. And,
Sounds good.
And right, Doo-Sik, do you want to say some last words about your experience? Then we can move on. Doo-Sik, do you want to say some last words about your experience?
Yes, my patient had a very similar swallowing difficulties because of the large cystic encephalocele masses obstructed the esophagus, and she underwent preoperatively gastrostomy. But nowadays she cannot still, even after operation, she cannot swallow anything. It's bedridden, and I felt that we just only the brain surgeons we can remove all tumors, but we can. It's very hard to reconstruct, and also she complained of some meningitis symptoms. It's very terrible cases. So I strongly recommend you should not touch this patient. So you can remove the tumors, but we have to consider how to reconstruct this patient. How about your opinion, Leo?
I agree. I'm not too keen on doing this. I mean, it worries me. I think that it was mentioned that coming from a lateral perspective, we should be able to decompress the prevertebral space. The issue is not so much removing it, but what to do with it afterwards. How to rebuild this upper cervical spine injunction, and also the fact that she's doing well. You can see from the pictures, other than the aesthetic issues, she's standing, she's walking, she's talking, she's doing it all, but she does have pain. She does. This is the issue why she's been dealing with this for years, and now this year the pain has become less tolerable, and so she sought help, and then that's why we're debating the case here. So
yeah, definitely not an easy case, because trying to help for pain, we can cause more problems and difficulties for her. So if you guys agree, I'll move on. I have one case that I would like to present to the panel. This is a patient, my understanding, in her 40s. It was presented to me just yesterday. as what to do next. And I want your guys' help and take a look at this. So let me share the pictures. Do you see this picture here? Can you guys see it?
Yep.
And so let me show you this, probably the best picture here. So it does not enhance. It's a lesion in the interpeduncular fossa, and this is the stalk in front of the lesion. The pituitary gland is right there. So here's what happened. This patient was taken to surgery through an endonasal approach, an experienced surgeon actually, and perform a transposition of the gland as he describes. And it apparently tried to work through here, but was not able even to biopsy this mass. The patient, my understanding, didn't have symptoms other than there was some more like an incidental finding. I think there was an episode of confusion, and the patient has been having headaches, but not vision is fine, as you can imagine, optic nerve somewhere here. There is a little dislocation. If you see here, this is located really in front of the brainstem. It's bright in T2. He thought was a cyst, so he was gonna transpose the gland and pop the cyst, but he got there and he felt it looked like more like neurotissue firm, and he felt that he didn't have space to do much with his mass. And then he stopped, and he was asking for me what to do next. So I want to see what you guys think. Apparently there was a little bit of calcification. I haven't seen. I don't have. These are the only images that I have. He is actually sending me more images, and he said there was a little bit of calcification. So he thought was cystic cranium doing the case, but he said that doesn't look like that. He was not able to get any pathology. So I don't know what you guys think about this lesion. It does not enhance. Doo-Sik, what do you think? You have a lot of experience with this.
The patient didn't undergo the biopsies.
No, so he tried to get there. He said he transposed the gland, but he felt it was too narrow, a little bit of venous bleeding. He kind of got anxious there, and then he stopped. And he told the family, we'll send you somewhere else for surgery because, I cannot do this. And then he called me, like, what to do next here, like, should we drill more clivus and try to go lower? Because he apparently didn't drill the clivus. He tried to do through the sella. I can try to share one more time here. See, these are pre-op images. I asked him, like, can you send me the post-op? And his answer was, it looks the same, Danny. It looks the same. So he said it's going to look the same. But he said he'd disconnect the gland, but I'm not sure if he completely removed the dorsum sella. He said he tried to remove the dorsum sella, but he couldn't really do much. He said it was too narrow and got some venous bleeding and stopped. And he never biopsied. So the first question, I guess, for the panel, what is this? And if you have any idea, does it really need surgery? See what I mean?
Let's see the coronary MRI images, and I think that the tumor is not the stock-origin tumors, maybe more higher positions tumors from the hypothalamus.
Yeah, it looks.
You have to exclude the hypothalamic hamartomas. How about that?
Yeah, see, in T1 with contrast, it's almost like ISO. See, it's maybe a little darker, but ISO does not enhance. See, this is without contrast. This is with contrast. And I only have these 4 pictures. I'm sorry, but that's what I have for now. It's sending more. I can bring it back in the future. But see, the chiasm is right here, and it's kind of posterior to the chiasm and posterior to the stalk. And in the coronal T2 is bright, very bright. And there's no edema on the brain, see?
Yeah,
See,
no,
I was, the question I have is, could this be a hamartoma? Like it could be something that we shouldn't touch, you know, I don't know. Maybe is it similar? That's what I'm wondering. What do you think, Doo-Sik?
Yes, I think the baby hypothalamic hamartomas. If the patient has no the seizure-like movement, if you want to take a biopsy, first endoscopic third ventriculostomy, and we can take a biopsy from the third ventricle. But if there is no symptoms related to the mass, right, symptoms, and then we just only follow the patient.
Yeah, the interesting part is that he already tries surgery. So but my understanding, the family is under the expectation that, you know, like, you know, got to do something here. And that's part of the problem. What do you think, Swish?
Yeah, I think it's pretty enhanced mass, right? So it could be some sort of exophytic glioma. Yeah, of course, the hamartoma is another possibility, but maybe some sort of optic pathway glioma or some exophytic glioma.
Yeah, like a low-grade glioma, right? Some sort of
right,
something like that.
How's her vision
Apparently normal.
and pituitary function after surgery?
Well, he said that was DI that he created, but it has resolved after a couple weeks. This apparently surgery was not even a couple months ago. It was just a few weeks ago. And that was transient diabetes insipidus, but it's better, he said. And the other hormones apparently are fine.
So I think the issue is two issues. One, should you do anything? Because it sounds like she's doing very well, other than the social issue. And two, if you were to do something, where to approach it from? Because it seems like the transposition would be doable, but you have to take out a lot more of the clivus, right? I know this is pre-op, but if post-op is the same thing, it sounds like maybe a more thorough approach would allow you to reach the lesion. The stalk is pushed forward, the optic nerves are pushed forward, so it should grant you a decent corridor there, should you decide to do something.
Yeah, let's say we want to just biopsy.
But what about, have you done redo transpositions?
I haven't done a redo transposition, no.
Has
I
anyone?
from somebody else. I don't remember doing that.
Yeah, I don't know if that's feasible.
Right.
Especially if there is pituitary function.
Right. The question I have for Doo-Sik, like, see, the gland is up here, the stalk, and I think the floor of the third ventricle is pushed up, in my opinion, here. So if you come from the top, what do you think? You try to go a biopsy. How would you do the biopsy here, Doo-Sik? I don't know if I understand. Would you try to go with the endoscope through the ventricle? It's kind of narrow, or with a needle?
Endoscopic third ventriculostomy. Yeah,
Like
using the endoscope, enter the lateral ventricles. So maybe foramen of Molo. Yeah, foramen of Molo is maybe very narrow, but we have to be very carefully approach the lesions, and then finally we can reach out the bottom of the third ventricles, maybe bulging out. Of course, and pituitary stalks may be act as an obstacle to may develop the post-op DI, but still very carefully. Minimal dissection.
Yeah. And I think the other option might be more aggressive, taking this clivus here, coming endonasal, and then with the 45-degree kind of go up. See what I mean? More like a transclival approach may be the way, because if there's a lot of scar around the pituitary gland, Leo, and it feels that, let's say, I think you probably can disconnect it again there, but probably getting more room inferiorly, you can come this way as one option. Because, you know, there's the basilar plexus is definitely bigger superiorly versus inferiorly. So maybe the venous bleeding that he got here was kind of a part of the issue, kind of drew more and come this way. What do you think, Soichi?
Okay, I will do biopsy through the transnasal still, but that's the best way I think. I'm not sure why. I don't know why he could not control the venous bleeding, or why he had some trouble accessing this tumor. But I will try again.
Mhm.
Yeah, transpose the gland and make a sufficient space.
Yeah, because I'm thinking, go again endonasal for that, because I understand Doo-Sik's idea. It looks so narrow, and the fornix, I don't know, Doo-Sik. I look at this, it's like it's really tight here. I guess it's possible with with a small, what is the name of that small endoscopic one? There is a OI, I think, right? Is the OI the one that is smaller?
No more produced. OE is right, correct? But the stores does not provide.
Oh, they don't produce it anymore. I see. So what are you guys using in terms of endoscope, since you brought that up? If you need to do third ventriculostomy, what brand of endoscopic intraventricular are you using? Or you still have the old ones?
Yeah, I use the same. It's maybe I don't know the type, the name of the type, but ventricular scope. And but even though even if small size the foramen of Monro, we can minimize the injury of the fornix, and a little bit coagulation of choroid plexus entering the foramen of Monro, and we can access.
And don't you think that what if this is below the floor of the third? You still go through there as we're doing a third ventriculostomy and then get a sample, right?
Yeah, just only sample.
Right. Yeah, I guess you're right. I think it's just as long as you can identify the mammillary bodies, right? Because when I look at here, I think the basilar is somewhere pushed there. I guess you can map that better, but it looked like the arteries there's nothing in the way here. You can probably get a biopsy there. What do you think, David?
Thanks. Well, I think first and foremost, better imaging is the way to start. I'd want to get a diffusion sequence and see what this looks like properly. Just in terms of the scopes that we use, Baby Lotto might work, or the Minop. I wouldn't consider a endoventricular approach, endoscopic endoventricular approach. I think it's too difficult to get into those ventricles and maneuver around. I mean, similar to the previous case, I'm struggling to understand the indication here. I mean, in a way, the indication is because the patient's family are expecting a surgical experience. I guess for me, the single most important indication is what is the mass? I need histology, and for that, I would consider a stereotactic biopsy, navigated stereotactic biopsy, transfrontal. Get the diagnosis from that. And frankly, I think a pterional approach, if you're going to actually try and resect the mass, is probably, in my hands, the simplest and most effective.
How would you do that? Like, do you think you can reach like from this pathway here? You're thinking kind of the pituitary stalks push forward?
Yeah, I think the tumor's done some of that work for you, and I think with a bit of frontal extension, we should be able to get there.
Because it has expanded there. Yeah, I don't know. My experience with the retroinfundibular interpeduncular fossa. Sometimes you get there and the optic in the way, and the chiasm is prefixed, and even if you dissect up, like it may be difficult, but I think you're right in terms, if you depend on the goal, right? If the idea is to sample and get a little piece, probably you should be able to do with that pathway as well. Christina, what do you think?
I think I agree with Leo and David as well. The indication piece. I think I understand that there's a certain, navigation of discussing someone else did pursue surgery, and then kind of pulling the patient's family back from kind of that original idea of a surgical kind of, I guess, management for this tumor or process. I also agree with David in terms of additional imaging. I think, you know, hematoma is very possible. I don't think they're usually as bright on T2 as this, but I think additional sequences would be helpful to kind of maybe narrow down that differential. And I think I agree, if ultimately the decision is surgery, I will phrase it more as diagnosis. So we know what this is going forward, you know, how frequent do we observe if we're not resecting it, and all of that. You know, kind of in the beginning of my career, in terms of doing a transposition kind of on its own, it's already challenging. Doing a redo on someone who previously had DI, that indicates to me that the plane probably was not great and probably won't be great when you go back in. But in terms of a biopsy, I agree, taking more of that flyvis will give you the angle to at least get a piece of this tissue.
Very good. The any other idea, Leo?
I agree with David. I wouldn't want to approach this endonasally for a biopsy only. If you're thinking about resection, it's a different story. But if you want to do a biopsy, you can do a stereotactic biopsy. Will get you the tissue you need without great issues in terms of vision or pituitary function, and then you go from there, because then you know what you're dealing with. And like Christina mentioned, how often should you, is this something you should pursue in terms of resection, something that's going to threaten her even if she's doing well now? Is this something that you should, how often should you follow up with imaging and so forth? But I think the stereotactic biopsy should be somewhat straightforward.
So let me like bring this up. Let's say, okay, so now we're going for the biopsy. I'm putting the images again. So now we have three options right now on the table here, right? We have the option of coming back endonasal. We have the option of Doo-Sik with the small ventricle, but navigating with the endoscope through the ventricle to get there, and understanding that the floor of the third may be pushed up, and putting a needle through the frontal, as you guys said. So I would tell you, like, I don't have a lot of experience with the needle through the frontal for something in the interpeduncular fossa. Can you guys, like, wouldn't you be worried about the optics here? How would you plan? Would you try to do stereotactic, like kind of making a plan through the entire pathway to come through this way? Or would you go more lateral here through the thalamus? Or what is the best way to get there? It's like, I guess, the similar, like they go through the hypothalamus and down here. Is that the best way? I just don't have experience. What do you think, David?
So, I mean, I do a bit of deep brain stimulation implants, and, you know, that very often we'd be placing in the subthalamic region. So I think it, you know, usually a frontal trajectory that navigates just below ventricles between the internal capsule should be able to get you there with relative ease. You just have to be very, very careful that you avoid major vessel pathways. And generally speaking, these deep-seated biopsies are found to be very well tolerated.
Okay. Yeah, it makes sense. So it's similar to this coronal, but more frontal, right? Because this is probably more posterior and near the internal capsule. But if we shift this to more anterior, I think the angle, right? You can, but the entry point will be somewhere similar to, you put like stimulators on this lower aspect here. You would just go through and get a sample there, basically. You think that's the best option?
I think
less morbid,
lowest risk.
less risk. Then you don't deal with the fornix, and you don't deal with the optic nerves. You don't deal with the big surgery. Couple hours and you're done, right? Maybe less than that.
Should be less.
All right. Yeah, maybe. Thank you for bringing that up. This is why we discuss here. The any other comment about this case, so we can think that was well discussed. Let me stop sharing. Do you guys have any other quick case to present? Any other challenge you guys are dealing with? I'm gonna read one question online here that we got an email from Iran, just to finalize your thoughts on this. This is a patient was admitted 2 days ago in Iran, and I'm gonna read the email. It comes from them there. How would you manage a 67-year-old man with coagulopathy disorders who came to emergency department because of a right-sided vision loss due to an intracellular solid lesion? The optic nerve and superior cavernous both involved. Consider endoscopic or open dural removal to access. The sinus ligation and coagulation is challenging in this case. I don't know if I understand very well, but what did you guys understand the question? There's 67-year-old coagulopathy disorder, right side vision loss involving optic nerve and superior cavernous, and they're considering endoscopic or open dura, and they are thinking about sinus ligation and coagulation. Is that any issue? Do you see any issue with somebody with the coagulopathy? I think coagulopathy is, I think they're saying based on maybe anticoagulation is there. Do you see any problem with this, Doo-Sik?
I can understand what's going on.
Yeah, this is the email we got at so let's say the question here is somebody losing vision and has like blood thinners on board, do you take emergently to surgery if somebody is anticoagulated? Let's say losing vision, and I had a situation similar not too long ago, like a person is with one of these anticoagulate, like let's say warfarin, and has an apoplexy and start vision loss. Do you take to surgery or you wait? Soichi.
Okay, I will bring the patient to the OR, and of course it depends on how severe the coagulation problem is. But still, I will explain all the risks he had, and if the patient agrees, I will remove the maybe hematoma or the tumor. Yeah.
I guess depend on the type of anticoagulant. Do you then try to reverse whatever you can, right?
Sure.
Is that what you do, Christina?
Yeah, I think it depends on the indication. Can we reverse it? Can we do a heparin bridge? And then just having a detailed conversation with the family in terms of the risk and benefits of, not doing anything versus doing something. But then I think if you're going to go in, you have to make sure you get everything, whatever tumor you leave, there's a high risk of obviously, bleeding again there.
Yeah, Doo-Sik, if that's the scenario, that's what I'm kind of trying to understand from this question here, vision loss and anticoagulation. Is that what you would do? Or do you wait?
Yeah. For me, I will do the surgeries even after evacuation of the hematoma, the decompressed optic nerve, and then we hope no more bleedings from the tumor cavity or hematoma cavities. I think the tumor remover or hematoma remover is the first choice of the options.
Leo, what do you think?
I think it depends on what coagulopathy you're talking about, because like you mentioned, warfarin is reversible, but we have these new generation of oral anticoagulants, which are, I always question neurologists. They just start patients on this, and we get all these giant brain bleeds, not only apoplexy, but brain bleeds, and there isn't much you can do in terms of reversing it. So I've had situations not in apoplexy but in brain bleeds where the family is adamant that we should go in and drain it, regardless of what could happen because of the anticoagulation. And sometimes you get there, and even though they are on the drugs, it's not as bad as you anticipated. And on other cases that it is catastrophic. So I think you need to check what kind of coagulopathy we're dealing with here. And like someone else mentioned earlier, how severe is the vision loss? But I would likely favor surgery. Yes, because I don't think that if the patient is deteriorating, is something you can wait. But you have to talk to family and say, listen, we're in a pickle here. If we do nothing, this is likely the outcome. But if we do something, it could lead to a even bigger problem than we started with in the first place. So I guess it's all.
Yeah, that's what I did, and it's very interesting. This is just a week ago, and I had or 2 weeks ago, and I had two at the same time. I was on call, two patients in the ER, one with vision loss, and it's very interesting. Both were a little older, a woman and a man. He presented with a frozen eye and some obtunded. And the lady presented first with vision loss and confusion. And then she was the first one who came. I went and talked to the family, and my initial idea was, let's wait. She was with anticoagulation, but then I was called again. I went to see her. She was obtunded, really in coma almost. I repeat CT, there was more blood. And she started, I look at her eyes where I like this, she started getting like third nerve palsy as well. So I decided to take both at the same time at the end of my day. So I finished my elective cases. I did one and I did the other one, and I finished midnight. And we did all of them. And then and I did exactly like what you guys told me. Try to really reverse as we can, talk to anesthesia, call pharmacy, what is the anticoagulant that is there. Some of these antidotes are very expensive, turns out, right, Christina? And not everywhere in the world, I think they have, Leo, some of the antidotes for some of these new generation ones. We're not going to go through all of them here, but that's kind of what we did. We end up using some very expensive antidotes, took to surgery. In both cases, I was able to maybe remove 80% of the mass, it becomes very firm, and this clot mixed with tumor. So we decompressed, got pulsations, and one of them I got into the cavernous sinus a little bit, decompressed, because the symptomatology for the gentleman was more frozen eye, and then we kind of reversed, and then both got a good result. Both start getting improvement on their functions afterwards, and it was fine. And then at one point we restarted heparin, right, because they needed for whatever other disease they had in their hearts and things like that. Go ahead, Christina.
I think the other thing I felt to mention is it depends on the pathology as well. I think Leo mentioned that, I think it's different if this is a meningioma and this is a slow progressive vision loss that for some reason now, maybe he woke up this morning and happened to close one eye and noticed that his right eye is blurry. That has been going on for a longer period of time, versus an apoplexy where I feel like that's that immediate change in the volume and compression against the optic nerve. I think if it's a slower process, then you have some more time in terms of reversing, seeing how the labs come down, getting agents, or you don't have the agent to reverse, then waiting it out for it to wash out of the system in terms of knowing the half-life of some of these other drugs.
Yeah, and there's a lot of data. It's a good point, because sometimes you don't need to do surgery, right? You just replace a steroid, give some hydrocortisone and wait. And I've done that a few times. I remember a gentleman in his 80s that had partial third, partial six, and blood there. And then I decided to just wait. And it's interestingly, I never operate on him. The tumor disintegrated afterwards. We watch it, the nerves went back to normal. It takes a little more time than my experience. If you do surgery, you give a chance for the improvement to happen faster. But if you don't, the tumor kind of collapses progressively, the nerves wake up, and it might take a few weeks, but you see that improvement as well. And as long as you're on top of the hormonal replacement right away, there's a lot of data out there that you got to balance those things. If it is only 3, 4, and 6, usually I think I'm more likely to lean towards observation versus when there's vision loss. And that was my concern with the lady that had vision loss and expanding bleeding. I repeat CT and it was bigger. I was like, man, I don't think I can justify this lady bleeding more through the night and doing nothing here. So that's why I decided to just do it. But those are challenges. I remember when I was in University of Virginia, like that was the first time I heard from Dr. Newman there, like that, you know, to be conservative. He was an ophthalmologist, neuro-ophthalmologist. And he was always like, you know, like this gets better. You know, don't worry. Most of this apoplexias, particularly involving the 3, 4, and 6, they do get better. So, you know, some case by case. I also look at the status of the patient, how old the patient is. I think is very important to consider. I think younger people, we are more likely to take to surgery. In older people, I think, you know, the stress of surgery may be something to consider. So maybe being conservative on those. That's another, you know, thought we always have to have. Any final thought about this? David?
Yeah, so if this is a chronic condition, or an elective surgery, I'm quite insistent. I would make sure that the anticoagulation is addressed. Emergency cases, so life and vision threatening, I will operate and will do intraoperative adjustments with FDPs or whatever necessary.
Yeah.
My experience, and I wonder if it's similar to yours, is that actually in many of those cases the bleeding hasn't seemed to be as catastrophic or worrisome as I'd anticipated to be. I've been somewhat surprised. I was expecting torrential, difficult hemorrhage to control, and in most cases it turns out to be a bit of a non-event.
Yeah, I
don't know if
agree. It's
that's,
just that clot that is mixed with tumor and it's hard to kind of, you think you're going to drain blood. No, it's actually a formed clot that is difficult actually to take it out. But it's decompression usually is possible. So, well, I think we're at 10 out of the hour here. So we'll, if you all agree, we'll finalize or one of our, you know, tumor board of our skull-based committee of the World Federation. So thank you all so much, and we will get the recording and put it in YouTube for everyone to watch it later on. Thank you all. Appreciate it. And Doo-Sik, I'll see you in 12 hours or so.
Yeah, see you.
See you there.
Bye.
Bye-bye. Good.
Bye.
Have a good trip.
Good trip.